Hello, welcome back. This is the third of the videos on reporting skills. And it's going to talk more about some of the stylistic issues, which, while they might not seem so important, and you're right, they're not so important, but they can really have a profound impact on how the clinicians read and interpret your reports. For radiology residents, this is kind of challenging because each of us attendings have our own particular stylistic loves and hates, and you guys feel that you've just learned how to do it one way, and then you move to a different section or work with a different attending who says, no, I really don't like my reports like that. So, I'm sorry, and I can't have any impact on that. At some point, you just have to try and go a little bit with the flow, and you'll learn any particular pet peeves that attendings have, and you'll develop through seeing all of these different approaches to reporting your own style, which you will use when you go out into practice. Just to show you a couple of comparisons between two early OB reports that I might consider. The content info both is pretty good, but the styles are very different, and I think there's definitely a preference for this first one shown here. However, if you look closer, you may see that there is something in this report which does not fit with some of the issues that we were talking about in our last little video. Look at the measurements. I hope you notice that here we have millimeters and here we have centimeters, which is something that we try and avoid doing in reports. This is another early OB report. I'll just let you kind of look through this and try and work out some of the issues here. But, these are both normal early OB reports, and yet you can see that for a busy clinician, this one would be a lot more challenging to work out as to anything that one actually needs to do anything about. And the answer is nope, it's just a normal early OB report. Unfortunately, we found with radiology reporting, having seen many generations of residents go through the system, that you learn bad habits really, really fast. They tend to get worse, if anything, with time. Sometimes you would think that people improve, and sometimes there's a fairly early improvement and then a later deterioration. And you really have to be very constantly vigilant and critical of your own reports to make sure you're not falling into some of these traps. So the use of templates has helped us a lot. Templates are, in the history of radiology reporting, a fairly new, I don't say invention, but I guess invention, which are now becoming standard in a lot of areas. And they definitely have their benefits, but they can have their problems. So they are telegraphic in style, which may or may not be your preference. I quite like telegraphic, but a lot of people don't. Some clinicians like telegraphic, but some of them don't. They do ensure that all elements are included, which is something that is definitely good, and therefore, and may also, by just the content being very standardized, can, or at least have potential to improve communication between both radiologists and between radiologists and clinicians. They can cause problems if you don't spot that something is missed out, if you have filled in something on your template or filled in incorrectly, then it's going to appear as a gap like this. What I would recommend if you are using a standard template is really check that all the components on that template have been reviewed. One way to do this is to just click next field, next field, next field, listen to it saying that field, pancreas, adrenals, kidneys, and so on that template, and make sure when it comes up with that key reminder that you then review that organ or structure. Be careful with absent organs. We have all sent out CT reports and templates where it said gallbladder normal when there is no gallbladder, or the uterus is normal, and so on. I mentioned in the prior video that if you're using a template and the most significant major finding is buried in the middle of that template, you might want to just cut and paste and move that up to the front so it does not get missed by the clinicians. The key to all radiology reports is we're looking for quality, not quantity. And, you can, these are not mutually exclusive issues. But you can have a too short report, which is not quality, or too long report, which is not quality. So too short reports may not include key positives or key negatives. There may be some issues with too short reports in terms of coding and billing these reports because they don't include those elements we talked about previously. For example, in a total abdominal ultrasound and you've forgotten to mention the aortic measurement, then that can only be billed as a limited abdominal ultrasound, including things that are necessary for medical legal documentation, again, as we mentioned previously. So this could be definitely categorized as being a too short report of placing a nephrostomy tube. First of all, they're using a lot of abbreviations. Perc, neph, tube is not appropriate. There are a lot of things missing from here. There are no details about the exact tubes that are used, the approach that's used, the local anesthetic, and so on. So this would not be an adequate report either for documentation of what you did to the patient or for billing. What are some of the risks of too long reports? Well, clinicians may not read them. We, as I've said before, we're all very busy. We all tend to sort of skip read a little bit. Some of the important stuff may be buried in it. They take longer for you to dictate. They take longer for you or for the attending to be able to edit. Time costs money. This was a first-year chest X-ray report of a normal chest X-ray, and it certainly describes a normal chest X-ray. However, probably including the waiver on the end is overkill, and really one could limit this to normal chest X-ray. Notably, on chest radiographs, we do not have a list of things that have to be mentioned on every report in the same way as we do with an ultrasound. This is one of my favorite Winston Churchill quotes, and I like many of his quotes, and just kind of bear this in mind with your longer reports. Just because you say, well, I said that, and it was in paragraph 3 of 6, doesn't mean the clinician read it. It's very easy to put in a lot of kind of extraneous and redundant words that add to the length and complexity. And we'll talk about some of my favorite, or let's say my unfavorite ones, these later on. But these just add to the length and complexity of your reports. And I think quite a useful exercise sometime is to précis one of your reports to see how short you can get it while still retaining its meaning. And you'll be surprised at how you can abbreviate these often. A lot of information can be conveyed in a very few words. I thought this was kind of interesting. Archimedes' principle, 67 words, but the US government regulations on the sale of cabbage is nearly 27,000. And I also like this quote. I couldn't find who actually said it, but I found that this is often true, unfortunately. So for a normal report, how much information do you need to include? We could all have a very exhaustive list of normal structures on whether it's a CT or a chest X-ray. But I think one thing that is key is answer the clinical question. You don't want them coming back and saying, yes, but did you look at the liver? You say, yeah, of course I looked at the liver. It's a normal, abdominal CT. You want to say that the liver is normal, or at least the solid organs are normal. Radiologists, again, vary. We all have our normal templates. Some radiologists may just normal chest X-ray is fine. Some may have a 1 or 2 line descriptor of what a normal chest X-ray is. I think just being aware that there are some differences in how we dictate our studies so that you can kind of recognize that different radiologists have different styles and you kind of decide upon your own. And obviously, you don't know what the clinician's going to prefer. So, in the end, it's going to be what you are comfortable with. This is a sort of what I call the chatty style is sort of normal grammar and sentence structure. So just an example here, there's 5 by 7 centimeter well-defined tumor in the right lower quadrant, abutting the pelvic wall, but not invading it. A more telegraphic style might be using sort of more short, abrupt sentences. So 5 by 7 centimeter well-defined tumor right pelvis, butt side wall, no invasion. Both of these are absolutely fine. They're both accurate, they're both succinct, and really it's a matter of preference. Some radiologists, they tend to be the more senior radiologists. You can't do this quite so well when you're a resident. Uses a more personal style. So So, for example, I see a 5 by 7 centimeter well-defined tumor in the right lower quadrant that abuts the pelvic side wall but does not invade it. Again, this is perfectly fine. I personally tend to keep the use of a personal sense. So when I'm really doing my interpretive statement of what I think that is, because that is my personal opinion. For standard for tenses, we use the present tense for interpreting studies. So, the mass is larger than in 2012, but we use the past tense for procedures because when you dictate them, this has happened in the past. So, an 11 gauge catheter was inserted into the common femoral artery. Be a little careful with dates. There are certainly errors within PowerScribe or within any voice recognition system. When you do dates, you have to be a little bit careful of them depending. And somebody with an English accent, we tend to get more errors than others. Also, so you may find that instead of saying 9/7/13, you might want to say 7th of September 2013. For some reason, it often, with the word, if you're using the number 2, it often messes it up. Do be a little careful if that the USA uses its dates differently. So for those of you in the US who don't know, the 7th of September is going to be 2013 will be 9/7/2013 in the US, but it will be 7/9/2013 in the rest of the world. And as we have more teleradiology, we have more patients who are traveling and bringing their studies with them, this becomes an issue, and we have all been caught out before. So you're perhaps better in that situation saying 7th of September 2013 to be clear. Whatever style you use, really try and avoid using long, complex sentences that may end up being confusing, or they may end up with clinicians kind of skip reading in them. Separate different topics by paragraphs. And you can also try and combine your findings into a logical structure. So here's 3 different ways of saying the same thing. The one tends to get a little bit redundant, but either 2 or 3 are absolutely fine. Do try and make your grammar and spelling okay. It's kind of like, when you write your personal statement, you're applying for residency, you don't want somebody to think you're an idiot when you're not. And some of this might be that you don't know how to spell a word. Some may be because your voice recognition has mistranslated it, but do read through it. So for this next section, I do an apology. This is my mother, otherwise known as the Grammar Queen. She did send my kids, when they were about 8 and 12, grammar books for Christmas one year, so be warned. While this does seem a little bit fussy, these grammar errors actually can have a significant impact on how that report is interpreted. And we've all had clinicians come back to us and say, did you really mean to say? You can make things read a little bit better by moving the object to the front of the sentence. So, we often end up saying there is, like this, but you can amalgamate these all by doing this. So in this particular example here, 4 centimeter tumor, central necrosis is in the head of the pancreas with invasion of the splenic vein is a very clear and easily interpretable way of saying it. As I said, I tend to use active voice when it's my opinion. It's either mine, or if you're doing it as a resident, you can put we. This is our opinion. This is part of our value product as radiologists, and it's entirely appropriate to use that active voice in this setting. Okay, so here's where some of the grammar queen stuff comes in. Tautology and pleonasms are basically that you're saying the same thing twice in slightly different ways. I'm just going to give you a whole list of this for your amusement, if anything else. But just, you'll find that people dictate these a whole bunch of, and they are kind of silly. And again, they just add to the lengthy report. Here's more of these for you to think about. And one final set. For those of you who are interested, Yogi Berra was famous using tautological phrases and neoplasm and pleonasms, and you can Look them up on the web. They're pretty amusing. So keep it simple. Try not to use these confusing terms. We had a radiologist who loved using subjacent, superjacent, and circumjacent. And then we polled everyone to try and work out what they were. And of course, nobody apart from that radiologist had any clue. Don't mention weird radiological signs that are not going to make any sense to anybody outside of radiology. You're just going to have clinicians' phone calls here. You will probably need to spell eponyms carefully. Voice recognition doesn't pick them up very well, and your transcriptionist, if you are still using a transcription service, won't. Try and keep eponyms to the common and, as far as possible, non-radiological ones that are going to be understood by your referrers. And unfortunately, I don't know why. It's just because we're all a little bit rushed, or perhaps it's the quality of English education at school these days. But there are a bunch of things that are just plain bad English, or as the case may be, bad American. Putting in double negatives, very confusing. If it's not rare, does that mean it's common? Inhomogeneous, that's heterogeneous. Plurals, people often get these wrong. The plural of septum is septer. The plural of diverticulum is diverticula. And then there's this whole bizarre range of phrases that people don't use but outside of radiology, and they never used before they started doing radiology reports. But by about September of the first year, every radiology resident is sneaking these in. Is noted gets used, and I've seen radiologists residents reports that use the word is noted maybe 6 or 7 times in a report, where you can pretty much take out every single one of those. So try doing that. Same with is identified. Sometimes people use this term, there is no evidence of, because they think that if there actually was one, that they're not seeing, which, is a true statement. The patient has a supine radiograph, has a pneumothorax, we don't see it. Even in retrospect, we don't see it, that there is some kind of medical legal protection there, and there really isn't. Another one of these weird radiology speaks is that the finding is demonstrated. You just got to say it's there and what you're seeing. It's not demonstrating anything. It's not anthropomorphic. I personally have trouble with the words unremarkable. Does unremarkable mean it's normal? Or, what is remarkable? What's going to make you remark on this chest x-ray? Maybe I'll remark on something that's different than you're going to remark on it. So it's really a not very helpful phrase. Just say it's normal. Take out every word unremarkable and say normal. Exhibits, again, this is kind of more of an anthropomorphic characteristic. It doesn't exhibit anything. It just, it's normal echogenicity in this example. And again, this whole appreciated thing is a bit weird, and it's sort of more radiology hedge speak, really. Just, you don't say that you don't appreciate it. You just, it's not there, or at least you don't see it. The word to appreciate, here's the definition of appreciate. So that's not really what you're saying. I don't appreciate a pneumothorax. I mean, I personally love a good pneumothorax. Don't use the word lung fields around Dr. Black. He's not going to like you. These are lungs. And there is some very specific terminology that gets misused that actually has a different meaning that I want you to be a little bit careful of. Foreshortening is actually the optical illusion of shortening. So if the metacarpal is foreshortened, that means that it's just looking foreshortened because of the angle that it's imaged at, which is sometimes the case. Sometimes like the femoral neck looks weird because of the angle of the beam. So use the word shortened if you really mean shortened. Infiltrates are a pathological term. We want to say, so for us, we're really normally talking about an area of consolidation or interstitial opacity, a small area of opacity in the upper lobe. Infiltrate, try and avoid it. There's no verb or adjective called bony. Just say osseous. So it's an osseous abnormality. Echolucent and sonolucent are really very old-fashioned terms that we're not kind of People don't know how they're interpreted nowadays, so use anechoic or hypoechoic. Hip fracture is a layman's term. Joints dislocate, bones fracture, so it's a proximal femoral fracture. There is no word as epicenter in the medical dictionary. That's to do with an earthquake. So just say that the mass is centered upon. People get confused continuous and contiguous. An aortic aneurysm is continuous with the aortic arch, but a lung mass will be contiguous with the aortic arch if it's butting up right up against it. And affect and effect, I'm sure this was beaten into your heads in grade school, but people still get it muddled up. You may be surprised to know that there is no disease called alveolar disease or airspace disease. You know, that's not like chickenpox. It's alveolar filling or airspace or alveolar opacity or consolidation. Be particularly careful with the use of osteoporosis and osteopenia because there are very precise WHO definitions of these terms which are based on bone mineral density studies. So if you're going to use these outside of those studies because you're looking at a hand study, for example, on a patient with rheumatoid arthritis, use the term demineralization. And I'm not even going to go there with surgerize. It just hurts my soul. Be particularly a little aware of these judgmental terms. Both sometimes the clinicians get a little bit antsy about them, but again, you know, patients do now read their reports, and so be a little bit careful with words like obese and poor inspiration. And we have other words that we can use that at least are not considered quite so offensive. You know, the same is, you know, the patient was non-cooperative. You know, it may be because, you know, he was medicated or he just couldn't do whatever you wanted him to do because of physical inability. So I would avoid that term. And there are some terms that just need to go into radiology history. You know, you used to use abdominal radiographs, not abdominal flat plates or KUBs. I mean, you know, out of all the things that we see on an abdominal radiograph, the kidneys, ureters, and bladder are some of the ones we see least well. Wet reading, right? The last person who ever actually saw a wet reading is now 10 years past retirement from our department. So this is just a preliminary reading. Be careful with terms such as AAA. A AAA could be an abdominal aortic aneurysm or it could be ascending aortic aneurysm. So many of these abbreviations have multiple definitions for them. You know, we've all spent time when we get an abbreviated clinical history down from the clinicians, Googling it to see what on earth turns up. White out of the lungs, you should not be using that after first year of medical school. Stability has a very specific term when you're talking about fractures or dislocations. So if you say the left femur fracture is stable, that can mean it's unchanged, which is usually what we're talking about, or that it doesn't move or firmly fixed. So you're better to say the left femur fracture is unchanged when you're talking about bones. Reserve the word stable for actually when we're looking to see if something moves, such as a spinal fracture, or we're looking to see if the spondylolisthesis is stable, and so on. The word significant, we all use. I use it all the time, unfortunately, and I kind of beat myself around the head periodically. But, you know, significant is a statistical term. And when we're saying no significant findings, do we mean it's normal or do we mean minor findings that have no clinical consequence? And what I might call significant, the clinician might call significant, or the patient might call significant, may be very different. There are a lot of qualitative terms that we use, and this is actually kind of interesting. People have done research into this. You know, here's some of the qualitative terms that we use in our reports. That something is diagnostic of, suspicious of, consistent with, highly suggestive of, and so on. And let me show you one study that actually looked at these. So what they did here was they took a whole bunch of radiologists and clinicians, and they took these various phrases that you can see listed down here on the x-axis. And they asked them how likely they thought that abnormality was present. So, for example, if somebody said that something was worrisome for cancer, what was the percentage likelihood that that abnormality was going to end up being cancer? Was it 80% likely, 50% likely, and so on? And these are the kappa scores of agreement between radiologists and non-radiologists, which was really pretty interesting because, diagnostic of, both groups of subjects agreed that that was, pretty likely to be, they all agreed with how likely that was. When we look at some of these other ones, even ones like highly suggestive of, I would have thought highly suggestive of was pretty obvious. I was really, really concerned that that was going to be cancer in that patient. But apparently neither the radiologists or the clinicians, some of them obviously thought that that was not very likely, and some of them thought that that was very likely, as judged by the kappa scores. If you're not used to kappa scores, a kappa score 1 means there was complete agreement within the groups of the probability of that abnormality. So just bear these in mind. You may think that you're being totally clear, but you're probably not. There are some qualitative terms that we use just to sort of get you right. So mild, moderate, and severe are physiological adjectives. So somebody's in mild renal failure, moderate renal failure, severe renal failure, and so on. Slight, moderate, and marked are size criteria. So these are the ones that we should be using for things like cardiomegaly or pelvicoectasis. Now, coming to hedging, unfortunately, radiology and, probably deservedly has received a bit of reputation for hedging. Think about this. This is what the hedge serves as, an evasive statement to avoid the risk of commitment. I mean, is that kind of how we want to be known? We are professionals. We need to bring value to our product. And these are sort of hedge vocabulary, many of which I've alluded to before. So, when you're using some of this hedge vocabulary, and some of it is appropriate on occasions, just think about whether you really need to be including it. People think that they avoid lawsuits, but actually they can end up producing them. Berlin has done a number of articles in AJR about this. This particular quote here that you see was in one report that ended up being a lawsuit because it was sort of like, it's sort of hedge vocabulary, and it contains this thing, if indicated, a repeat view is suggested. Well, how would the clinician possibly know whether a repeat view is suggested or clinically indicated on the basis of this chest x-ray report or this chest x-ray? That's up for the radiologist to tell them. If something's 98% likely, don't hedge it. Lee Rogers said, don't let the fear of being wrong rob you of the joy of being right. If you have a bone scan that has a gazillion hotspots all over it, then in a patient with known cancer, say it's multiple osseous metastasis. Don't say it's, probably multiple osseous metastasis, because what else conceivably is it going to be? If you're equivocating, make it personal. This is your personal opinion. I doubt this is of clinical significance. A CYA phrase that gets used an awful lot is malignancy cannot be excluded. We can't exclude malignancy on any study, on any patient at any time. I mean, that's just stated, and it begins to lose its impact if you include it on virtually every report. So give them some idea of the indication of malignancy. If you think it's unlikely, then say you think that it's very unlikely, realizing, I just showed you that slide back there, that might be slightly necessarily going to be interpreted right, but at least gives you some idea. Many radiologists just have these multiple times in multiple reports. Here's a report from a resident, and you can see here, we have consistent with, cannot be excluded, cannot be excluded, cannot be excluded. Really, I mean, does this really come out as being a radiologist who has confidence in their interpretation? Clinical correlation recommended is the problem with this is not so much that there is an inappropriate phrase. Some clinicians have told me, and it was on our list of ones back in the first talk that clinicians hated, that they consider it somewhat insulting. That that by saying that, we make the assumption that if we don't say that they're never going to correlate the radiographic findings with the clinical findings. So, but what I think it does more is it sort of acts to shift the responsibility of clinicians. What I would recommend is rather you have this generic phrase that you are specific. So if you see, a little questionable lucency on a foot film of a patient in the ED who you've had the generic history of, trauma, pain, you don't know where they hurt, and you think, that might be absolutely nothing, could be a nutrient foramen, then say, something like, if the patient is focally tender, correlate with the exact site of tenderness, as this may be a fracture, or correlate with the liver function test in this particular patient. You tell them what to correlate it with. Just generic clinical correlation is meaningless. A large number of reports have been found to have transcription errors that significantly impacted on patient care in this study back in 1984, and I'm sure it's probably more than that now with PowerScribe. There are some specific issues to voice recognition editing that I can't prove this, but I think it's at least a good theory that when we used to dictate reports and then be transcribed by transcriptionists, and then we read them later that day or the next day, we read them much more carefully because we couldn't remember what we'd said, and we sort of read them through. Now, when we read through our PowerScribe or our voice recognition, I don't mean to pick on PowerScribe all the time, we know what we just said, and we read what we think we just said instead of the words that are actually there. Does that make sense? So we sort of we have a memory that we know that we said there was no pneumothorax, and so we read the words no pneumothorax when it actually says pneumothorax is present. So be ultra careful with voice recognition. So things that are very common that creep into editing are the sort of highs versus lows. So something is hyper, you meant hyper, and it says hypo and vice versa, or increased versus decreased. So read those particularly careful. Obviously, rights versus lefts get misdictated a whole bunch of times. You can actually have those capitalized in your program to sort of highlight it to you. Negatives get added in or removed, so be careful. There is no evidence of metastasis comes out as being there is evidence of metastasis, or there is evidence of a pneumothorax, and so on. A pneumothorax is not present versus a pneumothorax is present. Obviously, these have significant patient impact. There are certain words that voice recognition and transcriptionists often get wrong. Atypical and atypical, they're opposite. Asymmetric or asymmetric, adynamic or adynamic. There are alternatives we can use in these. Check your measurements very carefully. You don't want tens of millions of thousands like here. I talked before, be careful with the millimeters versus centimeters. I've been at many a tumor board where the clinicians are saying there's a 5 centimeter mass in the report and it ends up being a 5 millimeter mass. Micromolar and millimolar, micrograms and milligrams. Decimal points do not leave you must not have just this sort of trailing decimal point like this. So, in summary, reporting skills are as important as your interpretive skills. You can be the best radiologist in the world, but if you cannot convey that information, then you are a worthless radiologist. But they need to be learned. You can learn them. They require practice, and they require you to kind of hold yourself back and check. Do think before you speak. Try, when someone else is in the room, reading your report out loud and see if it sounds like you're an idiot, because it's read out in court, it's read out by the patient, that's how you're going to sound. Try and abridge your longer reports, see how short you can make them before you lose that key information we talked about. This Pricing is kind of a useful skill, and it helps you write abstracts for conferences. So here's the USDA definition of what can be called a frozen cherry pie. All right. Well, I précise that. And that pretty much comes out to be this. So the government clearly needs some good editors. So good reports contain accurate information for billing. They describe the significant positive and the negative findings using the correct terminology. And if you're a resident, they reflect the attending's discussion. They are clear, concise, and allow no misinterpretation. That your grammar and spelling is good, and you avoid unnecessary words and phrases that just add to the length and the complexity and decrease the understandability of your report. And you try and avoid these vague and hedging phrases. You really have to put them in. And you really, the key thing is you want to make sure that there is be no misunderstanding in how the clinician interprets it. You don't want them to read one thing when you meant something completely different. You do want to interpret those findings. Add your value product as a radiologist. Give some indication of the certainty of your diagnosis and provide them with some guidance for further management that's appropriate within the role of a radiologist. And then document notifications appropriately and accurately in your report. So think before you speak. Please edit your reports before we get to review them, and then sign them afterwards. Thank you very much.